The idea that we need to do a full comprehensive picture of looking at thyroid function. I think one also needs to look at thyroid antibodies. I think one needs to look at some of these nutrients that are very important for the raw materials for thyroid function, iron and selenium and zinc and iodine. So you need to look at that full picture. Thyroidologists, I think that conventional MDs or endocrinologists are starting to look at that. So it's not 15 years ago. I think that's happening now.
Should we be still screening for thyroid antibodies in absence of frank, overt hypothyroidism?
Yes, so I would say yes, because this thing now that we call pre-diabetes, when glucose is modestly elevated but not enough to be called diabetes, or our blood pressure is 130/85, which is borderline hypertension, it's going in the wrong direction. You can and should intervene in those situations. The same with finding, even in the absence of abnormal TSH or an abnormal T4, if you find elevated antibodies, then you know slowly but surely in almost all of those individuals, they are gradually going to lose thyroid function.
Hi, I'm Dr. Michelle Leary. I'm host of the new Vita Vitality podcast. We're so excited to bring this to you. It's been in the works for multiple years. This is a way for our doctors, guests, people who are experts in their field to then bring real-time information on what they're reading, what they're talking to their patients about, what they're passionate about, and translate that information directly to you. Hello, welcome to another episode of the Vita Vitality podcast. I am your host, Dr. Michelle Leary. I'm very excited to introduce our guest today, Dr. Dan Lukacer, who is a friend, a mentor, and a colleague of mine for going 13 years now. So very excited to have him. Little bit of a background for Dr. Lukacer. He is a naturopathic physician and educator with many years of experience in functional medicine and patient-centered care. I would add that he is one of the people who has really helped to form functional medicine in clinical practice for many, many clinicians. For the last 2 decades, he has served as the director of medical education for the Institute for Functional Medicine and has taught clinicians nationally and internationally with a focus on helping to translate complex systems-based medicine into practical clinical care. He continues to teach and see patients with his current focus on group-based education, which we're going to talk about some today. Shared medical visits, cardiometabolic, cardiovascular health, autoimmune disease, hormone health, metabolic resilience, and healthy aging. Dan, I'm so excited to have you today. Welcome.
Thank you.
Appreciate you being here.
I like the title, Vita Vitality Podcast.
Vita Vitality Podcast.
I hadn't heard that before.
Yes,
Very nicely done.
Because we all want to be vital,
Absolutely.
Right? That's what life is all about. Well, I asked you to be here for multiple reasons. One is you have such an amazing background in not only educating clinicians specifically, but you've been seeing patients for over 30 years at this point. So I'm wondering if you can just kind of talk about kind of the intertwining notion that clinical practice helps to inform education and how education has helped to inform your clinical practice over the years.
Well, that's a great question. I think that clinical practice, it's hard for me, but it keeps me humble because what you learn from practice is that it is not always, but often not everything that you've learned from research that is the kind of things that we all learn don't always work as they're advertised to work. So I think the combination of seeing patients and being immersed in both education, but also in understanding the research, I think it makes us all better clinicians and certainly makes us better educators.
Mm-hmm. Who was it that said statistical humans are of little interest? Was it Sid Baker?
He might have said that. I love Sid Baker, so he could have said that. Let's give him that.
Okay. It just came to me as you were talking. Is I think it's helpful for many of us in clinical practice to understand what the literature is informing us, but in reality, it's not always how patients behave.
Right.
Yeah.
That's right.
Yeah. Well, on that note, you have gone into a lot of different areas in your career. And one of those areas that you've lectured on extensively has been autoimmune disease and thyroid disorders. So I'm wondering if we could start there and just, number one, kind of talk about what about those conditions and areas is really interesting to you and how you see functional medicine as a unique approach for those conditions. And if you could define maybe a little bit for those who are unfamiliar with those conditions, what that means: autoimmunity, thyroid conditions, other endocrine-related disorders.
Would you ask like 5 questions
I
and
do.
I'm supposed to
Yeah, exactly.
answer them all, right?
One after another, exact order.
So I think I'm not going to answer any of your questions, but I'll come around to it. I think that what I find, one of the things that I find interesting about autoimmune thyroiditis or Hashimoto's and low thyroid function is how that has conventionally there has been some changes in the way that's diagnosed and treated. And I think that some of the things that we were doing maybe 15 or 20 years ago are not so out of the mainstream, or they're getting, I think there's an understanding, at least I'd like to think so, and I think the research suggests that there's an understanding that thyroid dysfunction, and we can talk about specifically autoimmune thyroiditis, in terms of the diagnosis of that, then we can talk about underlying root causes. But in terms of the diagnosis, it's more than just what was 15, 20 years ago was just doing TSH. Let's look at TSH. If TSH is out of the normal range, then we might look at T4. Or if TSH is out of the normal range, then then the lab will look at T4. But now I think that what I think we've been doing in functional medicine for quite a long time is looking at a larger picture of looking at thyroid dysfunction. And to me, one really should be looking at TSH, but also looking at free T4, looking at free T3, looking at these two hormones that are produced by the thyroid gland that are stimulated by TSH, and looking at that loop, but also adding on to that, looking at what's called reverse T3, which of course but if we think of T4 as the metabolic gas pedal, which is how I think of it, is that it stimulates every cell in the body to be more, in a general sense, just metabolically active, the gas pedal. We need to think of reverse T3 as the metabolic brake. And so if you can look at those two things in relationship and look at how they are, their relative amounts relative to T4, because T4 is this hormone that has to be metabolized down one of two pathways. It's metabolized down that reverse T3 pathway. So T4 goes to reverse T3 or goes to T3. So is it going down this metabolic brake? brake or is it going down the metabolic gas pedal? And I think that's very important to understand. Well, how well is this is the T3 that you have? So you need to be assessing T3, not just assessing T4, because T4 is really a pro-hormone. It doesn't have the activity. So you need to assess T3, you need to assess reverse T3, you need to look at those in relationship, and that helps you understand, therefore, what do you need to do? Do you need to give potentially more T4? Do you need to do things that and why is reverse T3 elevated, or why is it high in relationship to T4 and et cetera? So obviously I'm getting a little bit in the weeds there, but the idea that we need to do a full comprehensive picture of looking at thyroid function, I think one also needs to look at thyroid antibodies. I think one needs to look at some of these nutrients that are very important for the raw materials for thyroid function, iron and selenium and zinc and iodine among those. So you need to look at that full picture. And I think that I think that thyroidologists, I think that conventional MDs or endocrinologists are starting to look at that. So it's not 15 years ago. That wasn't happening at all. I think that's happening now. And so, when we're looking at that, that gives us a better understanding of how to start to treat, because I think that often, not always, but often we need to be thinking of with autoimmune thyroiditis, is there a need to do hormone replacement therapy? And then what else can we do looking at underlying causal effects? What can we do about inflammation? What can we do about that autoimmunity? What are the underlying issues around autoimmunity? Is there a toxin? Is there a food sensitivity? Is it celiac disease, et cetera, et cetera? So there's, I think, a great deal more to understanding, diagnosing, and then treating autoimmune thyroiditis. And there's most people, individuals with low thyroid, have autoimmune thyroiditis, but there is a 20 or 30% that just have a sluggish thyroid metabolism. And you need to separate those things out, because I think there's different therapies that you should be looking at. So I guess the bigger framework is what I'm looking at in terms of this thing that we call autoimmune thyroiditis.
Yeah, so I loved what you just said and I understood it, but I think for our audience, let's break it down just a little bit here. So when you're referring to markers such as TSH and free T4 and free T3, you're referring to biomarkers, which are commonly tested in blood. And for someone who is perhaps they've heard of the importance of the thyroid and they feel tired and they're noticing weight gain, that might be kind of the more common associations. If they're wondering, like, do I have this condition? And how do I find out if I have this condition? Maybe they heard that their mom has been taking thyroid medication for a long time, and so they're wondering if they now have it. How would you, from a kind of breakdown perspective, explain what the thyroid is responsible for? And you alluded to this in terms of if there is dysfunction, what are those common causes of that? What can people start to do about it beyond testing? And 3, if they go to their primary care doctor or their functional medicine doctor, what type of testing, again, you just said several of them, what type of testing are you recommending for those individuals to ask their provider for?
So to begin with, as I kind of alluded to, the thyroid and specifically this thyroid hormone. The thyroid delivers two hormones to the bloodstream, stimulated by this other hormone called TSH. So the two hormones, primarily it delivers this hormone called T4. T4 then has to be metabolized to the active hormone called T3. And then T3 goes to, as I said, every cell in the body has receptors for T3. And T3 basically increases the metabolic rate of all sorts of things depending upon what cell it's stimulating.
Does that mean more energy production?
That means more energy production, right? Stimulating this, the mitochondria, the powerhouse of the cell, stimulates that in various ways to produce more ATP, which is energy. So in the broad standpoint, that's what the thyroid is doing. It's stimulating, or if the system is too stimulated, or if it wants to shut down or slow down, then it has a way of doing that. And that's what I was talking about, reverse T3. So if you're so why would you want to slow down the thyroid? Well, if you're in the middle of the desert, don't have any food, you want to slow down your metabolism so you don't use calories as much. So that's the prototypical example, but there are many stressors on the system that slow down the thyroid. So individuals, and they've done studies, individuals in the ICU, that's a stress. Obviously, they've had surgery or something. They're in the intensive care unit. We know that reverse T3 is stimulated when you want the body in individuals who are in the ICU, or in individuals who are starving, or various other kinds of stressors. Reverse T3 is stimulated. So the body has the ability to either speed up or slow down the system. So there are many symptoms that are associated with, or can be associated with, low thyroid function. You mentioned, and of course, fatigue can be one. Anything that slows down the system can potentially be a symptom. Fatigue being one, but of course, there's many other reasons to be fatigued. You can have a nutrient deficiency, an iron deficiency, that can slow you down. But constipation slows down the system. That's associated with thyroid dysfunction or hypothyroid. Hair loss or dry skin, that's slowing down dermatologically your hair. So those kinds of things. But there are many other symptoms, such as muscle pain is another symptom. Cognitively, depression, that's slowing down, but also cognitively. So if you think, well, what's slowing down the system? Those are symptoms that could be associated. So if you have some of those symptoms, going to a well-trained conventional or functional medicine practitioner, then he or she would hopefully do, in their head at least, some kind of differential diagnosis. Is this a thyroid issue? And then getting those tests that I suggested, TSH, T3, T4, reverse T3, thyroid antibodies. At the very least, that's going to help you understand how the thyroid is operating. And then you asked, well, what are underlying issues of why the thyroid would be slowing down? And you can have nutrient deficiencies or insufficiencies, which is a good framework that we could talk about. What's the difference between an insufficiency and a deficiency? There are, as I mentioned, so there are nutrients, iodine, iron are important for the production of T4, for instance. There's also nutrients, selenium and zinc, that are important for the metabolism of T4 to T3. So nutrients conversion. Thank you. And then there are food reactions can be associated with thyroid dysfunction, celiac disease, which is a specific kind of reaction to obviously gluten, infections, toxins. All of those things can be underlying causes for thyroid dysfunction. So going to a good clinician who understands the bigger picture can use those kinds of laboratory to help understand, is that the underlying issue? And then additional laboratory tests potentially of nutrient insufficiencies or toxins or food reactions, et cetera, to see what are the underlying causes and how can we address those underlying causes.
I love that. I love how you explain that. And what came to mind, actually, I'll try not to say 5 questions in a row, but 2.
Do you like how I use my hands like an Italian? Do you like that?
I do appreciate it.
Good,
I was actually with you. One of the questions is around testing for thyroid antibodies without any evidence of a underfunctioning thyroid, or what we would kind of commonly see as a higher TSH and potentially a lower amount of T4 and potentially T3. So that's my first question, is should we be still screening for thyroid antibodies in absence of frank, overt hypothyroidism?
Let me answer.
Okay, I'll hold it.
Yes. So I would say yes, because just like we can have this thing now that we call pre-diabetes. So when glucose is modestly elevated, but not enough to be called diabetes, or our blood pressure is 130 over 85, which is borderline hypertension. I mean, it's going in the wrong direction. You can and should intervene in those situations. The same with finding, even in the absence of a abnormal TSH or an abnormal T4, if you find elevated antibodies, then you know slowly but surely in almost all of those individuals, they are gradually going to lose thyroid function. Can we intervene earlier to do things so they don't lose that thyroid function? So that's my answer. Yeah, I would say yes.
I agree with you. I think that the criticism historically has been, at least conventionally, once somebody has thyroid antibodies, they're always going to have thyroid antibodies. So what's kind of the point of tracking that? But I think if I understand you correctly, it's because there are interventions potentially nutritionally or lifestyle behaviors, and especially in the age of the GLP-1 era, as you said previously, when somebody is consuming less calories, we can see that reverse T3 potentially go up because there is less of a metabolic fire, or there is less energy consumption, thus the body. So I think your point is well taken, that we should be trying to intervene early, just like we do in prediabetes or other even autoimmune conditions. So my second question.
But let me
please.
just interject there and about, which is conventionally, as you said, if thyroid antibodies are elevated, never check them again because you're not going to be able to do anything about that. The literature is mixed on that, and that's where we get into the, conventionally, if the literature is mixed, if it's not black and white, then they say, oh, there's nothing to it. I don't think that's true. I certainly have seen in a number of individuals thyroid antibodies going down with interventions. And I think if you do see thyroid antibodies going down, that's a good positive thing. And that's why I check thyroid antibodies, and I also recheck thyroid antibodies after I've done, some intervention. So I think this is an area where I would say the literature is not entirely clear, and an endocrinologist could get up here and say, oh, well, you can't point to hard and fast, black and white studies in which all of those antibodies have gone down, or all of those individuals with elevated antibodies, they've all gone down and they've all gotten better. So I can't, but I think we can point to enough literature and what I would say are rules of reasonableness. If antibodies go down, you are generally doing something positive. So looking at that, I think, is important.
Okay. That's a great clarification. Just as a little bit of a dovetail, I guess, into that GLP-1 era, and thinking more broadly from an endocrine perspective, could you just explain for the audience, and probably for my benefit as well, kind of the relationship of the thyroid to the adrenal glands and the gonads and the hypothalamus, pituitary? Just if you could explain that axis for us, just so we kind of understand that the thyroid doesn't act independent per se.
Yeah, I think that another great question. There's a longer answer, and I'll try to give a shorter answer, but there is an axis of what I call the HPA-TG, so the hypothalamic pituitary adrenal thyroid gonadal axis. So they're all linked with, kind of at the top of the food chain is the adrenals. And the adrenals can have significant effects on all of those other hormonal glands, if you will, the thyroid, etc.
And the adrenals are what kind of gland? What do they do generally? Just so.
Well, the adrenals are the gland that secrete hormones that are involved in the fight or flight. So they secrete cortisol and adrenaline, depending upon if it's kind of long-term stress or short-term stress. So and those hormones have significant impacts on all of the other glands in the body. So the adrenals, so that's why you do need to look at, hopefully I'm getting to your question, you need to look at all of those in context, because if you're having a lot of stress, quote unquote stress, that stress is physiologically has to do primarily long-term stress with this hormone called cortisol, and cortisol has so many downstream effects on those other glands and hormones that one needs to be thinking about, well, what should I be doing about stress? What should I be doing about it in terms of lifestyle? How can we modulate that stress? And what should or can I do in terms of nutritional, botanical, and pharmaceutical support for that stress response? So, did I answer your question?
Yeah, I think so. I think I think of it as a superhighway. You may have been the one who taught me that originally, and this HPA-TG, kind of thinking of it as different off ramps, right? Depending on where you're going. But it's a highway that all kind of, if you get a backup on one area, it's going to impact the other areas, that they're not in isolation. One topic that, as you know, our good friend and colleague, Dr. Kalia Waddles, focuses a lot is fertility. And the thyroid is talked about a lot with fertility. And of course, HPA-TG, gonadal, meaning either the testicles in men or the ovaries in women, how the thyroid can impact specifically those organ systems, tissue types. So again, briefly, and I am going to be talking to Dr. Waddles about this, but why is the thyroid so important for the ovaries, and particularly for helping with conceiving or even maintaining pregnancy? If you could speak briefly about that.
Well, I'll let Kalia talk about that more in depth, but I'll just go back to, what I said before about energy metabolism and affecting this powerhouse of the cell, this mitochondria. And so if the thyroid is not working adequately, the body in particular, aspects of the body and physiology are going to be more sluggish, and that sluggishness can lead to different aspects of infertility.
No, that I agree, and definitely her and I will get into the weeds on that quite a bit. Kind of shifting gears slightly here, you've talked a lot in your educating of clinicians about the immune load from a kind of broad, not just the thyroid, of course, but affecting all sorts of different conditions. Could you define what you mean by this immune load and how it can push people one way or another? And what do we do about it if once we go down a path we're not wanting to go down?
Yeah, well, there's a couple of areas of immune load. If we're talking about autoimmunity, and of course, autoimmune thyroiditis is one of these many, many conditions that we call autoimmune diseases, from thyroiditis to rheumatoid arthritis to lupus to Crohn's to ulcerative colitis. They all have, in general, the body's immune system being out of kilter, and essentially it's I would say that the immune system is at some level very, very simple, and it recognizes self from non-self. And if it's recognizing or getting confused and looking at certain tissues, that could be thyroid tissue, that could be joint tissue, that could be skin tissue, and saying, this is not me, then it's going to, as the immune system, as that big system, is going to say, I'm going to attack that. And that's autoimmune disease. So that is one part of the immune system that gets out of kilter, as I said, and therefore you have a attack on oneself, autoimmunity. And so then you have to kind of look at, well, why is it doing that? Is there what is it about the system that it doesn't recognize? Is that a toxin? Is that a food? Is that something going on in the digestive tract that's making allowing different things to get through that shouldn't get through, this leaky gut or intestinal permeability? So that's one aspect of immune system gone awry. Another is, I think, that is at some level underappreciated, is this idea that we lose immune resilience. And that's not necessarily an autoimmune condition. That has to do with we're not able to bounce back as quickly, or we're not able to fend off certain pathogens of viruses or parasites or bacteria or those kinds of things. Susceptibility, thank you. And so there is this whole, I think, idea that can also be connected to longevity, health and longevity, is that if we don't have enough immune resilience, we're going to be more likely to be run down, more likely to therefore catch things. More, our system is not able to be as resilient or be as protective against the outside world. So those are two parts, at least if I see it, of what's going on with the immune system. Is it an autoimmune issue, or is it a immune resiliency? And I talked about, well, what are some underlying issues with autoimmune, but underlying issues with immune or a lack of immune resilience, that can have to do with stress, which has many tentacles in terms of nutrition or sleep or connection, but also nutrient insufficiency and deficiencies. And I think those are often underappreciated, and I think sometimes as we get older, people say, "Oh, I'm just getting old." So, and we do lose a lot of things as we get older. Immune resilience is one of them, but there are many things you can do to enhance your resiliency and to age with some gracefulness and increase longevity.
Yeah, immunometabolism being a topic that we don't have to get into today because it's a big topic, but being a hot topic of how, and we'll talk about metabolism in general shortly, but how things like blood sugar play a role in even immune system regulation, and even how fat cells can now be considered an endocrine organ, and how those can also impact our immune system because of the communication they have with producing certain types of inflammatory molecules called cytokines. So it's a fascinating area that you bring up. You said something, I think, that I want to drill down to just a little bit. You brought up this concept of leaky gut, which again, I have heard of it a few times, maybe twice. That a lot of our listeners, our patients, those who will be interested in this podcast are like, "Oh yeah, I know what leaky gut is." Could you define leaky gut, not only just in terms of the basics, but also what is happening when somebody has intestinal permeability, kind of the clinical term, and why does that contribute to this immune load you described?
Sure. Well, leaky gut or increased intestinal permeability is another area that I think 20 years ago or even 30 years ago that was derided conventionally. And it is no longer derided conventionally. I would say that it has, to a significant extent, has come into conventional medicine. Not everybody, but there's so much research on leaky gut and intestinal permeability that I think it's clear that we have to address it. So
can't avoid it anymore.
You can't avoid it anymore. So a leaky gut or increased intestinal permeability means at the very basic level, you have a leakiness of the cells that line primarily the small intestine. That those cells there is the small intestine is there is a lining that's one cell thick, and if those cells, which have if you will, shoelaces that tie them together, one cell to another, and those shoelaces, if they get frayed, those things go by the name of zonulin and occludin. Those shoelaces or microfilaments. If they get frayed, then things can pass between those cells, and that's the leakiness.
So starting with kind of a tight interlocking,
That's right.
And then as they loosen, then there's the possibility of immune cells going from the GI tract into the underlying component called gut-associated lymphatic tissue.
Right.
Correct?
That's right.
And then bloodstream connects from that.
Exactly. So they can get into the systemic circulation. They can get underneath that one cell that divides the outside from the inside, because this lining, the gastrointestinal tract is 20 to 25 feet long. It's still on the outside, if you will. And so if we have leakiness, and there are lots of reasons why we can have leakiness, from inflammation, which is caused by a lot of things, to nutrient insufficiencies, to certain drugs, medications, to alcohol. All of those things can cause leakiness. And I think some people say, "Oh, you have leaky gut or you don't." if I think that I look at it more as a dimmer switch, is how much is it turned on, how much is it turned off, because there's a back and forth there. If I had, which I did, a nice nice Pinot last night, that's going to increase marginally some leakiness in the gut. So it's a constant back and forth process. So if you have more leakiness and you have it on a regular basis by a variety of factors, then those things that are outside, poorly digested proteins, we have all of that bacteria,
outside being the tube,
the
digestive tract.
Right. So bacteria, not that we're going to absorb intact bacteria, but we'll absorb pieces of those bacteria. We'll absorb pieces of proteins, of poorly digested proteins. If that gets into the systemic circulation past that leakiness, then there is potential that that's going to cause an immune reaction. The body is going to react to that and say, well, what is this? What is this piece of bacteria? What is this protein? What is that? And does that look like thyroid tissue, for instance? And I'm going to attack this thing, this piece of bacteria. But if it looks like the thyroid tissue, maybe I'm going to start to attack the thyroid tissue as well. That's the genesis of autoimmune and autoimmune disease. So leakiness of that intestinal permeability can lead to a variety, a plethora, potentially. It doesn't mean that everybody who has a leaky gut is going to get this, that, or the other condition, but it's going to put you at more likelihood that you're going to develop those things. So, the old naturopathic saying of all disease begins in the gut, or when in doubt, treat the gut. Those are both old naturopathic sayings. And both of those things make a lot of sense, because we have this huge interface that if that interface gets compromised, a lot of problematic things can happen.
Yeah, that's well put. And I think the key point I want to underline is that there are, similar to everyone understands that diabetes is not a good thing for cardiovascular disease risk, or having high blood pressure is not a good thing for cardiovascular disease risk. Those are pretty common known conditions that have this association. I don't think it's as common to understand that this intestinal permeability or leaky gut condition is not a good thing for things like autoimmune thyroiditis. It's not a good thing for people who have rheumatoid arthritis or just have eczema, an inflammatory condition that can be associated with allergies, for example. The immune stimuli that come with that additional intestinal permeability can be a contributing factor. It may not be the sole factor or sole cause, but it's a contributing factor. So that was really helpful, I think, to outline. So I think what I would love to kind of maybe ask one follow-up question from that, and that is, how do people test for intestinal permeability? Is this just a diagnosis that their doctor makes? Do they have to get a colonoscopy? What is the testing for leaky gut?
Well, there's a couple of ways that you can test specifically for, remember I talked about zonulin and occludin. You can test for those particular analytes in blood tests, and if you have high levels of zonulin antibodies, for instance, that can be a diagnostic marker for increased intestinal permeability. So there are ways to test for that specifically. I think at least from my standpoint, one of the primary ways that I use is looking at what's sometimes referred to as a comprehensive stool analysis, in which that gives a lot of, or lets you understand much more clearly what's happening in the gut. How is absorption? How is digestion? What are the bugs in the digestive tract that may be good bugs? Do you have enough of the good bugs? Do you have too many of those bad bugs, or do you have too many of bugs that are, if they're not necessarily bad unless they overgrow? And all of those things that I just talked about, if you don't have good digestion, if you don't have good absorption, if you have imbalances, sometimes referred to as dysbiosis, of imbalance of these good and bad bugs, all of those things can mediate or increase or cause a leaky gut. So I think that while zonulin and occludin can give us, well, do you have this thing that we call a leaky gut? I think that looking at what are the underlying factors that lead to that leakiness are more important from a kind of root cause of what can we do about it. So yes, you can test directly for leaky gut. There's some, I mentioned that test, there's some other tests, but I think more importantly, looking at a stool analysis gives us a really good overview of what's going on in the gut. And if you want to look at, well, is your gut leaky? You want to look at what's going on in the gut. So that's what I use.
Can you reverse it? Can you reverse leaky gut? Can you treat it?
Absolutely. Yeah, absolutely. I think there are many things that one can do to improve increased intestinal permeability or leaky gut. First, you want to take the things out that may be leading to that. So there may be food antigens, there may be toxins. Then you want to do things that improve the microbiome, the 400 to 600 different species of bugs that are like a fingerprint that we each have in our gut, and that are going to, if you have an imbalance, that can lead to increased intestinal permeability or leaky gut. If you have poor digestion, you may need digestive enzymes, you may need hydrochloric acid, you may need bile salts. You can evaluate that. If you improve your digestion, if you improve your absorption, then you can improve a leaky gut. You may have you may not have enough of the raw materials that are very important for those cells to grow. So that's things like zinc and glutamine. So you can replace, exactly. Repair the 5 R's as we talk.
What you're describing is, as functional medicine clinicians know, is something called the 5R protocol. And really, I think the piece that a lot of people are aware of is the remove, which is step 1. You mentioned, for example, if you're consuming gluten and you have celiac disease or even non-celiac gluten sensitivity, that is going to be a chronic stimulus that things may not resolve until you treat the root cause. Or if you have such as, mercury toxicity, and, mercury we know is adverse for every cell in the human body. And so that needs to be taken care of before we go on to adding just more and more probiotics and more nutrients. And I think that that's a piece that I see people unaware of sometimes, is what they need to remove. And they may just be using a lot of antimicrobials, whether they are botanical or pharmaceutical, as you've probably seen similarly. So I really like how you laid that protocol out, or those steps out. I really want to get to some of the interesting things you're doing in your practice, namely around group medical visits. So I think let's pivot over there, although I feel like I could talk about this whole kind of immune concept forever. It's just so foundational in my mind to so many other conditions. Let's go over to the group medical visits. Tell me a little bit about what are group medical visits? How do you define them with shared medical appointments? They're kind of used synonymously there. And why have you chosen clinically to undertake going in this direction in a group setting? What benefits do you see for patients?
Well, I think to take that last part first, I think really the benefits are that, you know, we see as clinicians patients on a, every 6 weeks or every 3 months or every 6 months. And while those individual appointments are critically important, group visits don't take the place of that. It's what happens between those appointments in terms of what they're changing. Lifestyle factors are, foundational to any kind of change, and to be able to do that, I feel that one needs to have more of a relationship, both with those patients, but those patients also, I think, get a great deal out of having relationship with other patients in a group. So, group medical visits or shared medical appointments are, two sides of the same coin. The shared medical appointments are really what the terminology is from an insurance reimbursement standpoint, and and there's now a 15 to 20 year history of within the insurance model using shared medical appointments as part of the therapeutic endeavor, I guess. So shared medical appointments really allows patients to come together with a clinician, either on site or virtually. You can do it both ways. I've been doing it virtually primarily over the past 5 or 6 years, to allow patients to learn from one another, to allow patients to understand other patients' trials and tribulations. I think that if we're just trying to do something ourselves and can't or don't have the kind of framework to see, well, what are other people doing about this same kind of issue? What are other questions that they might ask that I wasn't thinking of asking, or maybe I felt too embarrassed, or just was not feeling that was an appropriate question. That it can be a great way to really develop connection and community, and to improve, which we're all looking at, improve outcomes. And there's a great deal of literature that does suggest that improves outcomes. So for all of those reasons, I have certainly over the past 5 or 6 years have really become very interested and enamored of how to organize patients into groups, or how to have them come into groups, because it not only, I think, I know, helps them learn and grow, it's also, for me as a clinician, a wonderful way to engage with patients in a model in which I get a lot more out of just saying the same thing, not exactly the same thing, but that you see patients and describing a leaky gut. There's nothing wrong with describing a leaky gut over and over and over again, but if you can describe it to 10 or 15 people and they get a better idea altogether, I think that's a wonderful way to proceed and to really get those points across.
Yeah, and I think there's ample literature on community and connection, and how having a topic in which people feel like they're not the only one, and at least I can speak from, as you know, I have a son who has autism, fortunately very high functioning, but there are times where I feel like I'm really out on a limb, different from other parents. But when I connect with other parents going through similar challenges, it feels more sustainable and I feel seen. And I would imagine, I've not participated in a shared medical appointment, but I would imagine that people who are going through different health challenges that you're bringing them together, they feel like they have more strength because of that community support.
Absolutely.
And
Absolutely.
massive value there.
There's, in this day and age, we're not at a loss for knowledge. There's, you can find that kind of information all over the place.
Yeah.
So that's not an issue in how many people proceed. The issue is, how do I put all of these things into practice?
Right.
How do I do them in a way that's that I can do, and in a way that's sustainable? And I think that's what working in community, that's what humans have done for eons, is work in community, work with a connection. And that's what, to get to the AI part of things, that's what AI, I would like to think, is never going to replace, is that connection that you have in any kind of connection you have, but connection in a class, in a shared medical appointment.
Yeah. I hope you're right. Time will tell.
I hope I'm right too.
You alluded to this just a minute ago. People really have endless access to information right now, but people are more confused, I think, than ever about what to do. They hear things on this podcast, or maybe they read a book, or they hear something different from their conventional physician, or something on the news. Why is there so much noise and discrepancy in this world of health information right now? And what, if you have any ideas for solutions, how can we help support people feeling more empowered and less confused?
That's a hard question to answer. I think the first part is perhaps not that hard. Why are people so confused? I think we've lost our bearings in terms of what to believe, who to believe, and when to believe it. And people are doing, which they should and can do their own research, but there is a lot of evidence that has been developed over the years, and people, unfortunately, I think, are looking for black and white, and it's very nuanced. So people don't like to hear that things are nuanced, and it's what Dr. Helen Messier would often say. Well, it depends. It depends on this and that. But so I think there are many sociological reasons in the 21st century of why we are at this place, and that we just don't we don't believe authorities at this point, and we want to look at that in different ways, and we want to come to our own conclusions. So that's I think the big picture. How to get past that, if I had an answer for that, I think I would be a lot more well known than I am. So I think that part of the answer is sitting down in connection with other people and having a conversation about that, and having having people understand it's a bit of a nuanced conversation, and hopefully having individuals, patients that you're sitting down with, giving you some uh, understanding that you have a certain amount of expertise, and that doesn't mean that there's only one way to do things, but you have to look at the nuances and you ask, well, what are the risks and what are the benefits and what do we really know about this and how can we dialogue about this as opposed to saying, I'm just I have my way, you have your way. What is the evidence and how is that evidence nuanced and how can we look at that?
Yeah.
Those are hard questions to answer, but I think I have to believe that part of the answer is to be sitting down with people and having conversations with them as opposed to talking across one another.
Mm-hmm. I agree.
What do you think?
Well, I've given a lot of thought to this topic, honestly. And I think it comes down to personalized medicine. And what I mean by that, there's a lot of different ways to define that, of course. Functional medicine being a synonym of personalized medicine. But I think we have to look at people's genomics. I think we have to look at their biometrics, meaning their wearable devices and what their real-time data is telling us. I think we have to look at their biomarkers and what some of those types of labs that are different from wearable biometrics can necessarily tell us. And I think we have to assimilate all of that data, which I believe AI will help us do this, because I don't think an individual clinician, unless they have only one patient they are assigned to, has the time to do all of this. But I think AI will help us understand how all of that data pertains to them, because the misinformation out there, I believe, is because it's trying to apply really general guidelines or general information. For example, a ketogenic diet should be implemented by everyone. Well, that's not accurate, and that's not what the literature says. It might be amazing for certain people with certain types of genomics and certain types of goals and conditions and et cetera. And then others really need to go on potentially a lower fat diet, ketogenic being a high fat. So that's just an example of a nutritional advice, which is probably the most scattered across different recommendations and opinions, and everybody has a different thing that they're doing. But really, it depends on the individual's response to X, Y, or Z. And it could be a supplement, it could be a food, it could be a medication. And this is where this information age, I believe, will start to come together with dashboards that integrate all of this data in one and help us understand what those guided recommendations are, similar to potentially a stool test that you mentioned earlier. Is that it's more targeted recommendations. You're seeing what is needed and what you need to do to help that patient. This is maybe going a layer. Actually, it's not that different. It's really just compiling all these different pieces and giving us real-time data. And I'll just mention one other thing that I found was fascinating, and I think you would find this really interesting, is that they found that people who were using wearables who had a diagnosis of inflammatory bowel disease, Crohn's disease or ulcerative colitis or collagenous colitis, when they were wearing a wearable that measured HRV, heart rate variability, they saw that a dip in HRV preceded a inflammatory bowel disease flare. And that was very empowering for people to then take certain steps, whether it be different pharmaceuticals or therapies or even lifestyle behaviors, to then modify so that flare could be mitigated or modulated in some way. And I don't think there's any blanket statement that says 100% of people, are going to respond to interventions on their HRV, but there are a subset that will. And that's some of the things that I think could empower patients as we learn to use these new tools.
Yeah, I think you articulated it well, Michelle. And I think that we're saying the same things. Really, it is a combination of genes and environment. How do you test those genes, and what kind of environment do you wash over those genes? So you're talking about genomics, which I think can be and is. It's come of age, and it's continuing to come of age. We're continuing to learn more and more about these genetic variations that we all have, and what is the best environment to put those genes in. And so it's a nuanced conversation. And while I am all on board and do a fair amount of testing, I think there are, and that testing will get better and cheaper as over the next decade, without question. And there are things that one can do of trial and error. And does this fiber work for me, or does that fiber work for me? Because that's personalized medicine as well. You don't have to necessarily have a test that says, oh, I should use this fiber or that fiber. You should, as an example. So you can do, and I'm kind of responding to, I think that I have, and I'm sure you have, gotten the kind of critique that, oh, functional medicine is all about using tests. Tests are very helpful, but functional medicine is a system of looking at dysfunction and disease and trying to look at it in an integrated whole. It's not dependent on, oh, you got to do this test and that test. That's helpful, and one should use that. But there are other ways in this day and age still that we can say, oh, does this fit? Does this work for me in terms of how I'm feeling about that, the symptoms that I get?
Yes, I agree with you. I definitely think that critique has been something I've heard for a long time, and frankly, I don't disagree with some of that critique. I think more than many professions, functional medicine does more testing, more medical professions. However, I think that the data that we have gathered in that process of maybe taking it a step further in testing has allowed for more precision-oriented recommendations. But I agree with you that for those who are shying away from potentially functional medicine due to either not wanting to do the testing or the concern around cost associated with the testing, there are absolutely different approaches functional medicine approaches that do not require expensive testing.
Right. Functional medicine is a way of thinking.
Correct.
It's not about testing. And to your point, there are plenty of both tests and these things like CGMs, these continuous glucose monitors, that are a wonderful avenue to, and you don't have to use them for months and months. You can use them for a month and, cost less than $100 and get great information about, well, what's causing my blood sugar to go up? What's causing it to go down? Yes. And it's, what kind of food, because what's going to affect you may affect me in a different way. And so that's the personalization. And that's where a lot of if you put that in the broad rubric of testing or objective information, I think that kind of objective information, or these things like this Oura ring or a Whoop, or looking at HRV, very, very helpful in giving that individual a understanding of what's affecting them. Not that everybody is going to respond this way. So it's that personalized aspect that I think is very important.
Yeah, I just I think the genomics came to me when we were talking about this, because I just did a webinar last week, and it was comparing, at least in my slide set, I was looking at polygenic risk scores versus a SNP pathway genomic analysis, and how those two things both can be useful. And just to define that for our audience is kind of polygenic risk scores being an assimilation of lots and lots and lots and lots of genes, thousands to even millions, that then have very small effects and that then can contribute to cumulatively an associated risk of XYZ disease. And those can be predictive for population, versus genomic SNP panels can be more informative, specifically for an individual level and for practitioners to utilize that. But again, the testing, I think, is not, as you said, it's not functional medicine, which is an operating system of looking at how we can help support the body becoming more vital, more vibrant, and resilient is ultimately.
And just to round that out, these polygenic risk evaluations and these SNP, these single nucleotide polymorphisms, these genetic variations, again, from what I was saying about thyroid and how I think that many of the things that we have been doing in the functional medicine community for a number of years are now coming into the mainstream. And it similarly with polygenic risk, that's going to be, it is in the mainstream and it will be more in the mainstream. It's just going to be used more and more. And I think, the old adage of, research to bedside takes 20 or 30 years. And I think one of the things that I'd like to think that functional medicine has done, and some of the leaders in the functional medicine movement, i.e. Jeff Bland, etc., have really brought the research to the bedside much quicker.
Yeah, I agree. Yep. In our last kind of segment here, Dan, because I think it's such an important area, you work a lot with those individuals with cardiovascular disease, but also cardiometabolic disease. And not everybody understands what the difference is. When someone says, oh, cardiometabolic conditions, what does that mean? And then if somebody has a cardiometabolic condition, does that mean they have cardiovascular disease? Could you define that?
Again, that's another area that I think the functional medicine community and education on this has, we've been talking about this for many years, and it has again come to the fore. So the cardiometabolic and cardiovascular are two sides of looking at similar things. So cardiovascular is looking at what is happening in the arterial wall, arterial and venous walls. What's happening at the wall? Is there plaque buildup? And we know that plaque buildup leads to increased risk of heart attacks and strokes, primarily, with other things as well. But so that's what cardiovascular. Cardiometabolic is dealing in a broader sense with certain ways in which, from a total body system, that we can have dysfunction. And that is primarily through this process of elevated insulin and what's called insulin resistance. And that's around blood sugar, insulin, and insulin resistance, which can have a variety of different effects throughout the body and cause problems in the liver, can cause problems in the kidneys, can cause problems in the brain. So that's what cardiometabolic. Now, so there are really, if you will, in the big picture, there's three parts to this kind of combining cardiometabolic and cardiovascular. You have to have, you want to be thinking about, first, is there a leakiness? We talked about a leaky gut. Is there a leakiness in the arterial wall? That's one issue you need to think about. The second is, do you have an overabundance? Do you have too many of these particles that are atherogenic? These are the LDL cholesterol or the ApoB particles that are atherogenic. So if you have leakiness to that wall, those particles are able to get underneath that wall and produce plaque. And then the third part of that triad is, do you have mediators, i.e. inflammation, that mediate that process? So where those things intersect is looking at, do you have these things that increase the leakiness of the wall that lead to these particles, these atherogenic particles causing plaque? There are many things that lead to the leakiness of the wall. One of them being insulin resistance, elevated glucose, but also toxins, various other things can lead to that. But that's where they intersect. So individuals who have a high particle burden, a lot of LDL, can have more plaque. But if they don't have a significant leakiness, then they may not have as much plaque. So we're looking at what is increasing that LDL burden, and what is the leakiness? What are the things that we can do about that? And then what is that inflammatory mediator? So that's where they come together. And I think we need to look at those both separately. What can we do about these cardiometabolic individuals who have a cardiometabolic problem, which is primarily insulin resistance and glucose, which can lead to increased leakiness and then lead to that cardiovascular. And from the cardiovascular standpoint, do they have too much of these LDL atherogenic particles, and what can we do about that?
So the broader, to underline or underscore some of the things you just said, kind of cardiometabolic being a little bit more of an overarching term, but really focusing more on the intersections between what's happening in the vascular lining that is impacted by things like insulin resistance and blood sugar, versus cardiovascular disease being a little bit more narrow and focusing more on atherosclerosis and what is happening in terms of plaque development. Both very important, but there is probably more progressive discussion around the impacts that we can make using lifestyle behaviors, certain pharmaceuticals, therapeutics to impact that cardiometabolic piece that are maybe less aggressive, maybe is the word to use, than the traditional cardiovascular therapeutics. And I really liked how you tied in the important piece around the vascular lining and how that leakiness, and I think of it in terms of that there can be cracks in the wall. I think we're saying the same thing. Right. And if somebody has a large amount of, as you said, LDL particles that have an ApoB on, I think of ApoB as a little hat on top of the LDL particle, that then if there's a lot of them, and they're small, right? Because we know size matters when it comes to LDL particles, then those little cracks or leakiness is more likely to get underneath the vascular lining and ultimately contribute to plaque development, which then makes cardiovascular disease present or emerge.
That's right.
What have you?
Yeah, just to expand on that a little bit, I talked about, which probably shouldn't have, LDL and ApoB. So there are a number of atherogenic particles, LDL being one of them, VLDL being another, Lp(a) being another. They all have in common this little cap, as you're saying, which is ApoB. So if we count the ApoB as is a better way to count those atherogenic particles. So that's it's not a newer test. It's a newer test for many people that you want to look at the ApoB. And then I agree with everything you said. And then just to clarify, when I'm saying cardiometabolic, that's combining two things. One, it can lead to, through the ways that I described in terms of that leakiness or cracks, it can lead to cardio issues, heart attacks and strokes.
Sure.
And the metabolic side is it can lead to a variety of other bad things that have to do with insulin resistance, blood sugar, which is problems with your kidneys, problems with your fatty liver, cognitive decline, senile dementia, PCOS, so infertility. A lot of things are attached to that metabolic. So they are connected in the cardio side, but cardiometabolic is a broader issue that I think we want to expand that, and what can we do to improve that cardiometabolic risk profile.
And again, similar to what I asked you about the thyroid biomarkers, what tests are you testing to assess cardiometabolic risk in your patients? What are top things you would advise that if someone's wondering about their risk profile, they're an adult, let's say they're, above 30. What are kind of baseline tests you're getting when someone walks into your practice?
Are you saying somebody below 30 is not an adult? Is that what you're saying?
I'm saying that potentially less return.
Is that you're going to get a lot of blowback from...
Well, that's what happens when you start getting older. You see the adult.
You're an elder millennial?
I am, indeed.
So just some of the things we talked about, or I mentioned, you want to test fasting insulin. You want to test fasting glucose. You want to test a long-term measure of blood sugar, which is called hemoglobin A1C. You want to test, I believe, you still want to test cholesterol and LDL, but you also want to test that ApoB, which is a very cheap, simple test to add on to that. And then to your point, you may want to test, are these particles small and dense? Are they like golf balls and they batter the arterial wall? Are they big and fluffy like tennis balls and they more bounce off? So you want to test small dense or large buoyant LDL particles. And I think that another easy part of that test is testing triglycerides and looking at the triglyceride, what's called the triglyceride HDL ratio, which is pretty easy to determine. It's, how many triglycerides divided by the HDL. That will give you a good, cheaper way to assess for insulin sensitivity and to assess those. How are those LDL particles? Are they small and dense? Or are they big and fluffy? So that is, in a nutshell, those things, testing that will really give you a pretty good idea of your risk for cardiovascular disease and your risk for cardiometabolic disease or cardiometabolic syndrome.
To put you on the spot, what do you like your fasting insulin at?
That's a great question. I like a fasting insulin being below 10. I think that is pretty optimal. Some people say below 5. I think that, what is an A versus an A plus? So that's what I like. What is putting you on the spot? What is yours?
I like below 5. I got to get that A plus. Yeah. So that's an ApoB. Same question. Where do you like your patient's ApoB to be?
Well, so below 90, but then you want to look at, what are the other risk factors that an individual has? So, and I didn't mention, which I should have, the other thing that I always get at least once is what's called Lp(a), which is, I mentioned that as an atherogenic particle that really is very, very genetically predetermined. So if you have a elevated Lp(a), that's not going to change. Now, there are some drugs in development now, but that's not going to change. So if I have somebody with an Lp(a), I want to make sure all the other risk factors like ApoB, so I'd maybe want my ApoB down to 60 in those cases, because you want to get all those other risk factors as low as you can.
Yep.
It's all in context. It's
It
all,
is all
what
in
is your
context.
risk? What do you want to do about that risk?
What about imaging, cardiometabolic imaging or cardiovascular imaging? Do you use that in your clinical practice?
So I use a CAC score to, particularly with individuals who are.
What is a CAC? Just for
a CAC is a score of how much calcium you have in the arterial wall in the heart. And calcium allows us to say, well, how much plaque do we have built up? And in at least a bit older individuals, and I say a bit older, 50 and above, if they have a lot of significant risk factors, i.e. a family history, and or elevated, LDL cholesterol, elevated ApoB, I will want to get, and it's not a hugely expensive test. It's often not covered, but it's, somewhere in the range of $300. Getting that gives me a much better sense of, if their CAC is 0 and they're 55, even if they have elevated cholesterol, that doesn't mean I'm, over the next 20 or 30 years, it doesn't mean I don't want to pay any attention to it. But I think that if their CAC is optimal, which is 0, and they're 55 or 60 and have elevated LDL cholesterol, elevated ApoB, I'm less concerned about that, because that's the evidence that they're building up plaque.
Yeah, I agree. I think it's a very accessible test to get a CAC score, and coronary calcium score is another term that is often used. And I have become slightly infatuated, only because I have access to it locally, of those who are willing to spend more money for further screening and doing something called a CT angiogram, which is looking at not only calcified plaque, as you mentioned, but also uncalcified plaque. It's not available everywhere. It's certainly something that, it's a realm of $1,400. It's not cheap. It requires IV contrast. There's some reasons not to do it. But there are a lot of reasons to do it. If somebody does have a strong family history and their blood markers are suboptimal and have been for quite some time, I think there's value in having that conversation. But at baseline, I absolutely agree with you that having the atherogenic particle measurements in blood work as well as a CAC score is a fantastic kind of baseline test for most people to undertake.
Let me just add to that, is that, we're talking about a lot of tests, and there's a broad spectrum of individuals who can afford those kinds of tests. I'm not talking about the lower 25 or 30% who are really having a significant economic trouble. I'm talking about that broad middle ground that are, the 30 to 80%. If you're above that, you have all the resources to get these, more expensive tests. But there are the tests that we're talking about, the panel that I suggested, if you can't, which you should be able to get from any conventional physician, and most of that, and I get a lot of that, and half of my patients are insurance reimbursable. You should be able to get those, and if you can't, those are a couple of $100. That CAC is a couple of $100. So we're not talking about thousands and thousands of dollars. You can get a lot of good testing that is not being done, that is past the very minimalist testing that, let's get a CBC and a chemistry and a lipid profile, which everybody has probably gotten. But there is, for a few $100 more, in my opinion, you can really dive down and get really important information, and you don't have to, quote unquote, break the bank.
Yeah, I agree. Well, in wrapping that section up, I just want to say you have done such a service, I think, to the functional medicine community of the years that you have taught clinicians how to help support that middle ground. And I think that that's been my experience of you, is that you have always kind of had that weighted balance of not going for necessarily the premier of every single test that if you had unlimited resources. So I do appreciate that perspective that you've always had, Dan. So thank you. In kind of our last couple minutes here, you've had a long career and are continuing to see patients and contribute to this functional medicine community in robust ways. You have done clinical research. You have really developed and not managed, but really completely devised the functional medicine education program over 30 years. And now you're in this new chapter. What would you say your takeaways are for the future of functional medicine? And for those who are interested from a patient perspective, but also maybe a clinician perspective, what would you say your projections are for functional medicine in this movement that we're currently seeing in 2026?
I think that functional medicine, what I think that we all together have helped foster, create, and bring forward is some, not all, is getting infused into mainstream medicine. And as talking about Sid Baker, a while ago, I mean, what he would say is that it's just good medicine. That's what we're talking about, just good medicine. So the conventional medicine isn't bad medicine. Functional medicine is not bad or good. It's combining those two things. And I think there are plenty of important things about conventional medicine that I'm going to continue to use and do. And I think functional medicine is some of those things that are starting to get infused into conventional medicine. And I see that as a good thing, with the caveat that I think that we need to expand our understanding of what is looking at systems biology and looking at personalized medicine. And I think I'm not so sure about the world as we know it. There's a lot of problems there, but if the world survives, I think that functional medicine has I would say I'm cautiously optimistic that will continue to grow and be infused into good medicine.
I appreciate that. And I give you a hard time from here and there occasionally, but the whole community is in such gratitude to you, and you've just touched so many lives and so many people you haven't ever met because of each clinician you've taught. They have had that impact on their patients, and I hope that you can receive that and just know that there's a massive amount of gratitude. So thank you for being here. This has been another episode of the Vita Vitality Podcast. I'm Dr. Michelle Leary. Thank you for joining us.